Hello everyone and welcome to the Dental Learning Center. With us today is the expert in all things dental, Dr. Homer Goone. You know Dr. Goone, since you've been on the show we've received lots of questions about your name. Can you tell us a little bit about the Goone name?
Well, Marie, my name isn't really Goone. That's a name given to me by my adoring students. When I first began teaching, I was known by the students as Dr. Goone, and the name just stuck.
Oh, well. Moving right into today's topic, we're looking at a patient with a maxillary Kennedy Class 2 arch. Let's describe our clinical findings. In terms of occlusion, the patient is an angle Class 3, with end-to-end occlusion. The periodontal condition is good, with the exception of number 4 and 5, which have a guarded prognosis. After being harangued and browbeaten by Dr. Stickfigure, the oral hygiene has improved. There is a frenal attachment which could interfere with placement of a bar-type clasp on number 11. The patient is aesthetic conscious, but has limited funds.
As always, we begin with a thorough medical history and carefully articulated diagnostic casts. Referral to Dr. Stickfigure has given us the opportunity to evaluate the periodontal condition and to ensure an adequate recall sequence for the patient. We'll get Dr. Stickfigure to address the interfering frenal attachment on number 11. We've evaluated interarch space and decided that we have sufficient space to place artificial teeth using an acrylic base. The patient has not had any previous partial dentures. We have several treatment approaches here, but treatment with a removable partial denture seems a logical choice, since it is very conservative and affordable. Implants may be considered at a later time, if the patient so chooses.
Okay, when do we survey the diagnostic cast?
First, we'll place our maxillary diagnostic cast on the survey table with the occlusal plane level to the table. Then we'll use our analyzing rod to examine the cast for potential guiding planes, locate and measure areas suitable for retention, locate interferences to the path of insertion, determine areas of recontouring, and determine the most favorable path of placement. After we do all this, we'll mark our heights of contour and tripod our cast. Of course, we should not neglect to examine for aesthetics, especially dark triangles and clasp location. We'll look at our carefully mounted and verified casts to examine for occlusion. We very much prefer to avoid areas of habitual contact. The patient does not appear to have a retruded mandibular position that varies from her habitual closure, or MIP.
What's next, Dr. Goone?
Let's design the partial, starting with guide plane placement. Definitely a short guide plane on the distal of number 11, being careful not to over-prepare the tooth. Then, long guide planes on the lingual axial wall of the bicuspids and molars, as shown in the diagram. Next, we want to place rest seats. We'll consider potential fulcrum lines and clasp types here. Let's use the double occlusal on the mesial of the molar and distal of the bicuspid. We'll extend the rest on the bicuspid to provide some stabilization. We'll also rest the first bicuspid with an extended occlusal rest to provide resistance to lateral movement of this periodontally weakened tooth. A cingulum rest is placed on the lingual of number 6 and 11. That puts our fulcrum line as shown in the illustration. Now we're ready to join these components across the arch with a palatal plate major connector. The connector is extended so that the base will cover the tuberosity area. Draw the bead line on the cast. Okay. I think we measured the interarch space and decided we had enough room for an acrylic base with acrylic teeth, so let's draw the latter base retention. Time to consider clasping. Our surveying determined that the molar has 0.01 inch undercut on the disto buccal, perfect for a cast 1/2 round direct retainer. We have known that the patient was aesthetic conscious, but could not afford an attachment on number 11. We have two options. One option is to place an abbreviated cast circumferential clasp on the distal 1/2 of the tooth. Or use a modified T with 0.01 inch distal undercut. I prefer the modified T, because it resists rotational displacement of the partial denture, it is reasonably aesthetic, and the clasping adjacent to the edentulous space is inherently more efficient. Let's draw those clasps. Okay, now what?
I think the indirect retainer.
Yes, that's right. Look at the fulcrum line once again. Indirect retention is provided by the rests on 4, 5, and 6. Also, the partial can be easily repaired if these bicuspids fail. In both cases, the retentive element engages the tooth posterior to the fulcrum line.
That means there's less stress on the abutments, because the clasp disengages when the patient bites down. On behalf of the Dental Learning Center and Dr. Homer Goone, thanks for tuning in.